like to thank you for inviting me to this talk. It's very exciting to be here. It was also very informative to hear the speakers before me. Before I begin, I'd like to say that Dr. Finley said that his R&D group is an artist colony in a military camp. Well, I'd say I come from a rare species community, but that's changing. In early 1990s, or in late 1990s, there were 3 countries in the world that were interested in discussing value for money through evidence generation. It was England, Canada, and Australia. So there were 3 HTA agencies we were dealing with. It was a nice life. There were about 10 people in the company who dealt with this, and the dossier had around 100 pages. Today, we do this in 35 countries or more. The meetings, as Dr. Stark said at the beginning, are sometimes like courtroom hearings, indeed. We submit dossiers anywhere from 600 pages to 30,000 pages, and there's hundreds of people doing this. So we are no longer a rare species. However, it is very exciting work. The question is, do we do it alone, or do we do it together with our partners in the healthcare system? And what we prefer to do is do it together. Partnership is a very big word. What it means to me is people who break barriers, are willing to walk out of their gray buildings, talk, and with or without government's collaboration or support, make a change in our healthcare system. Why do we do it? Why do we care? It's because of this. This is a picture of a patient going through a healthcare system. This is also a picture that healthcare professionals are faced with. As you can see, the path through the system from being aware something's wrong with you to when you're actually either taken care of or cured or on medication for life is a winding path. It's not straightforward. It's very complex and very costly. But all the people in the private and in the public side have one thing in mind. We want to make this a straighter course. Nevertheless, in Ireland, the reform is taking its course. Post-World War II, European healthcare systems, and also healthcare systems in the US and in Asia Pacific, have been created with the structure in mind of that time. They have to evolve. You have seen with the first speaker some of the advances we have made. The system has to evolve. And the system has evolved. In early years, we cared how many beds we had in the hospital, or we cared whether somebody was administered a test for diabetes. Today, we care whether their glucose level has improved or not. We focus on the outcomes, we focus on the patient, and we try to make the right decisions, whether it's at the national, regional, or at the local level. What the healthcare systems are faced with is a finite funding, okay? So we operate within fixed healthcare budgets. We are roughly at whatever 10% of GDP, and it ranges a little bit from country to country, but that hasn't changed much. Yes, our GDPs have gone up, but the percentage hasn't changed much. So it's very difficult to adjust the system from post-World War II to today within the fixed healthcare budget. Ireland is not alone on its journey. I worked with over 40 countries in my career. It's difficult everywhere, and everybody is struggling with this rational resource allocation. There are several ways how governments tackle this. One way is by demanding evidence to make better decisions. More information enables to make more rational decisions. How do they do it? Over time, decision makers have requested a variety of evidence. We know safety efficacy has been the cornerstone of every single new technology debate, either in a hospital or for a pharmaceutical product, doesn't matter. And we have to produce this evidence as pharmaceutical industry, which is interested in investing in areas where we can make the most difference and bringing our innovation to patients, okay? Over time, decision makers have evolved in their thinking. They said, efficacy, safety is great, but an average clinical trial takes 10% of the eligible population, which is going to show up for treatment in an office of a physician or a practitioner. So we need to understand whether the promise that the clinical trial gives is actually realized in real world. We need to produce this evidence to demonstrate that there's value to our products over time. So this debate starts with the beginning. It continues for the life cycle of any technology or new intervention. Beyond that, they're also interested in the efficiency in the healthcare system. Why? It's a fixed budget. Unless we find funding within that, there will be no funding for new innovation. We have very little leeway here, so we have to find efficiencies. Now, what we have sort of produced as pharmaceutical industry, and you're all colleagues in this, is clinical trials that address safety efficacy. We produce real-world evidence or outcomes research data to address long-term benefits of the product in real-world clinical practice. And then finally, we are now faced with producing solutions that are actually tackling the costs and benefits of the healthcare system. The question is, shouldn't we do it together? Shouldn't we find something in this that is beneficial for all of us? Okay? And what I will share with you are 3 stories from 3 countries similar size to here, where I would like to show you how we can improve patient outcomes, how we can find efficiencies in the healthcare system and allocate our resources better, allocate the physician's time to those patients that need them the most. And finally, how can we bring this debate to a higher level in the government so one day we will not be fixed with a fixed percentage of the GDP, but that will become a flexible number. The first case comes from Greece. Greece and Ireland at some point were on the same place. It was tight. And thankfully, Ireland has moved on and has sailed out of difficult times. In Greece, the pressure from the Troika and various monetary institutions is weighing heavily on the people. And these are the people who work in public healthcare system and on the private side. This is a story of partnership between the national payer, covers the healthcare for 10 million Greek patients, MSD, and the Professional Physician Society. And what we observed in the case of melanoma, you've seen the pictures with the tumors. We do have new technology that helps with this, is that the people who work in the public healthcare system, the national payers, are struggling how to bring innovation to their patients when their throats are cut on the budget daily. And what they thought is, we have an existing electronic medical record system. And they thought there are people out there who know how to use this. So they got in touch, and we worked with clinicians to basically utilize this existing electronic platform to create a system of collecting data on patients with oncological conditions and enable the national payer to actually introduce technology earlier than they would have otherwise. Why? Because they are able to observe what the patient outcomes look like over time, and they're able to say, we no longer fund this. It's not getting used by the right patients. It's not getting used at the right time. It's not delivering value. And we're willing to take that risk because we believe that we would like to deliver treatment which is actually beneficial to patients. What do clinicians get out of this? They get access earlier. They go in the office in the morning, and what they tell us is they say, you know, I went in yesterday and I thought this was the end of it. I had nothing else to offer. Now I have something else to offer to my patients. So this is a story from a country which is in a very difficult economic situation. But through partnership, through bringing together the heads and the resources, we are able to find a solution for the patients and ensure that their outcomes improve over time. And if they don't, we stop, we change. It's not forever. The second case comes from Belgium. Belgium, 10, 11 million people. It's a very interesting country with a very fragmented system, regionalized. Electronic medical records are all over the place. Nothing is systematized, so it's not so easy to operate. And there's a north and a south, which have traditional differences. What we put in place here by collaborating with the Professional Society in Cardiovascular Disease, with the Regional SIG Fund and us, is a disease management program which enables physicians to find patients who are in high cardiovascular risk categories. The issue they were facing is that the records they had, they were not visible to them in the office, so they couldn't see where the patient was, nor were they able to quickly calculate or present to the patient where their healthcare risk is, the cardiovascular disease risk is. So what we enable them to do is to prepare an algorithm which reads their database on their computers and calculates the cardiovascular risk for a patient entering into the practice, displays it on their computer. So they're able to have an intelligent debate with their patient about where they are and where they should be moving, and also use this information to guide their treatment decisions, but more importantly, their time. How much time do they spend with a patient who's in the high category, and how much time do they spend with somebody who's relatively well managed? The Regional SIG Fund is engaged with us. The National Association of SIG Funds said, if you can prove that this works, we will pay for its implementation in the entire country. So next year, we will harvest the data, see how the clinical outcomes look like, and hopefully prove the case that it is worth investing in electronic solutions like this one. The last case comes from Sweden, a country in terms of the evidence-based medicine we all look up to, because they have data. In 2009, Swedish government made a strategic decision to invest in healthcare technology. So what they did is they created a framework for collaboration between peers and providers, academia, and industry. In that framework for collaboration, they have established over 100 registers for diseases. So they follow patient-level data over time. We are able to connect the data with death registers and with various other data sources. And this environment has led to tremendous investment in this country, both privately as well as from the public sources. So these registers become self-sustainable over time. What I'd like to share with you is a case from a rheumatology registry. You heard about the NTTNFs and the way we operate in rheumatology space is very debilitating disease. But what I like to show you is that this sort of evidence and the partnerships between these different partners is able to produce data that elevates the healthcare policy debate to a higher level than just the Minister of Health. So bear with me. This is a picture of a patient who is diagnosed and treated for rheumatoid arthritis, and this is their number of days off work per month, okay? So at the time of diagnosis, they take half a month off. Minister of Labor is listening really carefully because they have to pay benefits from their part of the budget. Now, what we are interested in is what happens before that. Does this happen overnight, or is it over time? No, it actually happens over time. So this slowly creeps up. So these are months before the diagnosis and treatment, right? This slowly creeps up. A lot of days accumulates, this younger population. And then the question was, what happens to those that are actually managed properly or don't have the disease? Those are their days of work, okay? So what happens is that if we move this bar a little bit further down, can we keep the curve lower down and reduce the number of workdays lost? This is very important to other parts of the government in order to have an informed debate how much interventions, how much investment should go into these parts of the healthcare system. With that, I'd like to sum it up. The public and private side have different expertise. They also have common expertise, but there's unique expertise on each side that can collaborate and bring together the results which are unprecedented. Okay, you've seen some examples from before with IMI, with the other aspects. These are three very simple cases. It takes people to get from behind gray walls, talk, and do it together. We bring expertise in research on both sides. We have resources and connections, okay? We have technical IT solutions on both sides that we can combine. We have data. We have the knowledge of the clinical pathway. Why? Because our partners on the public side, they do it every day. They can tell you, you don't ask them, what's your need? You ask them, what didn't work for you last week? And they'll tell you. They will tell you. And they have the patient perspective, which is very important because that brings us back to that winding journey. Can we take the slack out of it? And if we do have a government framework that enables this collaboration in place, like we do in Sweden, and like the Finnish government just introduced, then it's much, much easier. So if you can advocate for it, do it because it'll bring investment, it'll bring prosperity, it'll bring transparency in the system. And that enables us to really take the limited and the finite healthcare resources we have, find inefficiencies in the system, and invest that in innovation. This is a journey. Healthcare system is transforming, and industry is evolving. Like I said, I was a rare species 15 years ago, no more. There's more and more of us. And people are listening in the companies. The barriers with the public sector are broken down. I gave you 3 examples. Other speakers gave you more. There is more examples. We just need that sort of a critical mass of these partnerships to work so that that fear that we are somehow villains and we are not interested in collaborating in solutions in the healthcare system, they can be taken away. In my world, evidence-based world, they are taken away by proving that certain projects work and they improve patient outcomes. They deliver efficiencies in delivery of healthcare. And they can guide us towards investment in the disease areas that need the most help. So join me on this journey.
Well, Dr. Sasonov, thank you so much for that. I mean, I can think of very many questions and comments on that. Who'd like to start? Go ahead.
Thank you very much. The government here do have very good collaborative framework when it comes to research. So SFI encourages collaboration between academia and pharma. And it's been proven that you're much more likely to not only to publish, but publish in high quality journals with high impact factors if you collaborate with pharma. I suppose how would you propose using that model to move into, while our health service is good, it can be fragmented very much like Belgium, where down at Cork University Hospital we have one little database, and up in the Mater they have another database. How do we bring all of that together so we can use the model that SFI have within our system here?
It's a very relevant question, and I will answer honestly. Innovation comes in small steps. So first I would take a look at what are the strategic priorities. Then I would take a look at where are some technical enablers, like if there is any data in any part of the system. And then I would try to see whether there's interest in the industry for actually moving those efficiency debates forward. By coupling these 3 together and using the framework for collaboration which you have, I would create a few pilots, which then help us show that the programs work. The Greek example I gave, this was the 3rd collaboration. It came very slowly. And today I received a note saying that the payer is actually establishing a research group within the national payer that is going to look after these collaborations in the future because they get so much benefit out of it. So a few strategically placed collaborations where this can actually happen will show the outcomes of these, or the key performance indicators, which I think will then entice others who are sitting behind and perhaps not engaging in e-health or not engaging in the debate to see, okay, these people are improving patient outcomes. They are making our doctors' lives easier. They're finding resources to fund innovation. Why don't we try and copy it? I think through a few strategically placed cases where you already have the infrastructure in place, with this agreement, I would try it that way. Because it doesn't happen just like this. It's like I said, people coming from outside of their walls, working together, and it's hard work. It's not peaches and cream.
And can I ask one follow-up question? How the pharma collaborate, so take an example of hepatitis C, a lot of new drugs by different pharma companies. How do they collaborate to make this a reality? So how did they pharma come together and then interact with the health service to make these a reality?
So I could use the Swedish example for this, where a structured agreement is in place in order to address also hepatitis C. So each of the pharma companies has a seat at the table where the database that follows hepatitis C patients is actually designed, redesigned every year. Everybody pays a contribution. In exchange, they receive information about their products, and they're able to make, internal decisions, external decisions, and it's a fair process. And if they wish to invest further in research, well, that's a benefit for the holder of the data and the researchers who are part of it, and they can publish in very high-tier journals. So the collaboration is actually enabled through this structural system that the government puts in place. In other areas, like IMI, it was mentioned earlier, IMI case by the previous speaker. This is another forum where different pharma companies come together and collaborate. And there's a partnership for Alzheimer's disease. There's various others that are ongoing. So that does happen as well.
Yeah, they were very interesting examples, weren't they, Professor Healy? I don't know what your reflections are on this, or maybe you have a comment on where we are in relation to using this kind of technology.
Well, one thing that strikes me from your presentation, Vaska, a very interesting presentation, is that it's almost an impossible balancing act, is it not? Mm-hmm. You spoke about the resources we're putting in and trying to measure those resources, and then the outputs in terms of patient outcomes. And is it not the case that within a fixed budget, we are invariably not going to be able to get the outcomes for all the patients?
Yes.
And then on the input side, if you like, or on the resource side, one thing that struck me is the importance of measuring time and people's time, and either the healthcare professionals' time or the industry's time or the patient's time. And how good are we currently at measuring time? Because I'm not so sure in this country that we're particularly good at capturing that data that you've illustrated here is so important to capture.
We take it for granted. We're not very particular about it. But I think with the introduction of technology, right, electronic systems and things like that, we are able to optimize this. And like I said, there's precedents to these cases. There's many things that others are doing, learning from what has been done and adapting to the local system, I think is a way to go. And like I said, innovation comes in incremental steps, and I am dealing with this internally, externally, at all levels. But I think it is important to begin, because the healthcare system is rigid. It has to transform. The budget is fixed. You have to do something within that for now, and then advance the debate beyond it. But I think you're right. It's a balancing act, and it's a lot of work. I didn't put a winding road. It's a winding road in this.
I mean, the other thing that really came across very strongly to me is that we really have to reach out to other sectors. It's all very well to say we can collaborate within the pharma sector, and collaborations between the R&D people and the pharmacoeconomics people and so on. But the case studies you've shown have illustrated the importance and the benefit of engaging with other sectors, like big data, electronics, the whole environment.
It's extremely important. When I meet with the Greek national payer, I meet the head of research, the head of policy, and the head of IT.
Yes.
There is no way you can do this without them, because it brings that level of automatic system, because I don't want to burden the physicians. I want them to focus on the patient, right? Giving them yet another form to fill is not going to make them happy. It needs to be seamless. And they need to get the benefit. That's where the technology comes in. Yeah.
Delivers, yeah.
Exactly.
Yeah.
Exactly. And there's the whole regulatory piece besides this. These solutions are often medical devices.
Yes.
And trust me, I am teaching my colleagues on when software is a medical device. It's no picnic. So it's no picnic.
Yeah.
Maybe you need to do a bit more IT down there in the medical school in Cork.
No, I think with the schools, I mean, if you will allow me, I think putting this in the curriculum and teaching students about the importance of this is critical.
Yeah.
It's critical.
Can I just,
Yes, come back in.
just comment on doctors being, I know they know efficacy and they know effectiveness. What they aren't particularly good at is value or the costing of things. The cost of an antibiotic, the cost of a scan. So how you fit that into it, I presume it's through education, that there's one pot of money, how do we best spend it?
Yes, so this goes into a whole different debate on how do we educate the partners we work with, but we do. We have to, because otherwise they do not understand why we wish to do this. So there's basic education that needs to happen with the professional societies that we work with. And there's always somebody in there who has interest in this area. Outcomes research has been around since 1987. This week is the biggest conference going on. When I first went to it, was 70 of us. This year was 2,000 in Europe alone. So it has picked up. And I think by ingraining it in the curricula of the medical and pharmacy schools, evidence-based medicine is there, bringing the cost in. It's a natural thing because it's a finite funding system. And it's not going to change anytime soon. So we have to do it.
Could I just ask you, you showed that, I think it was a Swedish example of the rheumatoid arthritis and the figures. Now, you say the Department of Labour, obviously, and the social welfare system in Sweden are very interested in those figures. But do they talk to each other in terms of if the Department of Health can deliver better outcomes for people with rheumatoid arthritis, is that an argument for funding because there's a saving on the other side, yeah? Is there kind of joined up thinking there, yeah?
Correct. So they can team up, right? When the government sits down and allocates the budget, the Minister of Health suddenly has an ally. And the ally comes from labor because they pay for those days off. And Sweden is not a low-cost labor market. So they basically say, if I can have funding for these and these programs, they will save you this much money. So they do a simple cost-benefit analysis. They will save you this much money on the other side. But they have the infrastructure, the data with which they can demonstrate this.
Yeah.
It's really to be able to measure it, like you said. Go to the places where you can measure this and show them. Number is very powerful,
Yeah. All right. Well, I think we leave it at that. I mean, absolutely fascinating presentation. And thank you indeed for sharing that with us. Dr. Sasonov, ladies and gentlemen. Thank you. Thanks indeed, Dr. Excellent. Thank you.